Welcome, and thank you so much for joining us today. We are so happy to have you here. I am Emily Paisner. I'm the head of marketing for Daybreak Health, and today we are going to have a very important conversation about how school districts are helping to solve the youth mental health crisis that we're experiencing right now. As you probably know, it's Mental Health Awareness Month, but most of you experience this every single day. Our kids are struggling with their mental health and wellness, and the rates of anxiety and stress and depression and suicide have gone up. Our schools have really had to step up and provide more support than ever for students during this time. And based on the poll that we just saw, the majority of the kids in your district need more support, and they need it faster. So today we have some incredible panelists with us. I've had the privilege of speaking with them quite a bit before this, and they're going to talk about how they're managing this mental health crisis, how they're identifying student needs, and what additional resources and support they've put into place to meet those needs. Before I hand it over to Emily and Felipe to introduce themselves, I wanted to let you all know that we will be sharing a recording of this webinar after. You'll all get that via email. And if you have any questions at all, please enter them into the Q&A box. We will make sure to leave time at the end for any questions you have, and we'll try to get to as many of them as we can. Another quick note is that you might notice that Dr. Spalding from South San Francisco Unified School District isn't here with us today. His school district had unexpected teacher illnesses today, and he is covering the classroom, something I'm sure a lot of you can relate to. Emily, I'm going to hand it over to you to share a little bit about yourself and your role.
Hi, thanks for being here for this important conversation. My name is Emily Zavala. I'm a licensed clinical social worker, and I also have my pupil personnel service credential in the area of school social work. And my current role is the subject area coordinator of mental health and wellness. It's a lot of words for Eastside Union High School District. So we're a large all high school district in San Jose, California. With about, over 22,000 kiddos in our district. And we have a clinical team of social workers. So I oversee that program.
Thank you so much, Emily. Felipe, over to you.
Thank you all for coming and having this conversation with us. I think it's going to be fun. My name is Felipe Flores. I'm a mental health program specialist. I have a background in social work as well. And we have a smaller team on our side of supporting our students with mental health, and we're hoping to grow it over time. But it is something that our district is starting to look at. We do have a large district with 24 schools, and this is a elementary, middle, and high school. So we support all of our age groups in our district. And so we are hoping to meet the needs of our students as we go forward, recognizing that the needs are there.
Thank you so much, both of you, for those introductions. And so, Emily, I think I'm going to start with you. We'll make sure to get to both of you throughout the session. And I'd love to hear from you how the role of your school has really changed over the past few years in terms of the mental health resources and support that you provide to students and their families.
So I would say that the need has increased, right? So we're seeing just an overarching higher level of need for mental health supports that are on campus. We find that kids access supports most often when there's not those barriers in place, right? And so they're able to get access to care. And so the level of referral for service has increased. So I looked back at our last pre-COVID year, right? Our last normal, the last normal year we had, which was 18-19, and my referral count for the entire year for services was 3,200 for my district for mental health and wellness services. We're currently sitting at 3,878 referrals for service. We have the last 4 weeks to go, and we always get an influx of referrals at the end of the year. So we are on track to well surpass any level of referral we've seen in years prior to COVID. And so that's been the change, is really just kind of a growing need for especially services related to anxiety and depression.
So clearly the demand has gone up considerably. So how have you been able to adjust to meet the demands?
So I am very honored to work in a school district that is kind of a trailblazer in this area, because we have employed social workers for many years. I did my internship with Eastside back in 2006 when I was working on my master's. And so we are one district in the area that employed social workers, but I will say that in response to kiddos coming back to school after shelter in place, we hired 11 more full-time clinicians. So we went from a team of 20, I believe we were at 17 social workers. So that means full-time MSW or LCSW social workers on our team. And that expanded by 11, gearing up to meet the need. So we expanded our clinical team, and now we employ 28 full-time social workers. 4 of them work in our special programs or TC classrooms, therapeutic classroom setting. And the rest of them, the other 24, work on our comprehensive programs throughout our school district. So that was one way that we geared up to kind of meet the need. We also expanded our partnerships, including partnering with Daybreak to sort of supplement some of the therapy that we're able to provide, including the ability to connect kiddos to telehealth through Daybreak. So we really kind of bulked up with our CBO providers. We have grown some of the contracts that we had in place, right? So more hours from the contracts that we already had in place, and established new MOUs with various community-based organizations. And yet still there is not enough people to meet the need. So I still have wait lists for my kiddos to be assessed at all my school sites, right? That we can't even just do it day by day as the referrals come in. And so even with all that gearing up for supports, we still are finding a high level of need.
Felipe, I'd love to hear from you and about some of the challenges that you and your team have faced over the past year and how you've helped to solve for that.
Yeah, our team primarily focused on special ed. We were doing ERMs, so the education-related mental health supports, primarily in our district. So if you needed mental health, you needed to be identified as a special ed student. Over the COVID period, we switched our interns into being more supportive of our students. So we were able to support our gen ed students through our intern program. We didn't have a lot of interns. We had about, last year, I believe we had 8 of them. And with that number, we were able to support quite a few students. But that was still just kind of scratching the surface. As we came into this school year, we also had 8, we had to drop down into 7 interns. And so we've been really heavily pushing our interns into the schools to support our elementary school students, our middle school, and our high school students. Our counseling in that area has been able to support quite a few students, but still not enough. And similarly, we do have waiting lists. And our community is in Southern California in a kind of a rural area, so we don't have a lot of supports directly near us. So we have to share our resources with our neighboring school districts, which then overwhelms the pool, right? So it's like everybody's in the same pool, and the water has now exited, so there's no room for anybody else, right? So there's so much need in our communities with our other school districts sharing from the same place, that the waiting lists for those agencies are just really impacted. We use Care Solace as a referral service, and we have used them for the past few years, and our referrals really jumped this year. And this is all outside referrals through Care Solace, so helping our families connect with outside resources. And even in the first month of school in August, when we started, we had 71 people just seeking support, and that's just starting school, right? So just getting started into school, we had that many people jumping onto Care Solace looking for help, and it's increased monthly, just hundreds of people looking for support. So we've looked at different ways to support with what we have in front of us and what we have available to us. Daybreak is one that we have been able to utilize and support as our students need extra support and we aren't able to support them in our school with the resources we do have. So we refer out to Daybreak. Daybreak has been able to get our student support that they need virtually, which has been helpful. So some students are meeting with their therapist on the weekend. Some people are meeting them after school. Some people are meeting during school hours. So we've been able to, be flexible with that to make sure that the kids are getting what they need. But definitely, like, anxiety has risen. Grief and loss has been huge. Depression has been huge. Those are our three tops that we've seen from all different angles of what we've looked at, from student reports, from needs assessments that we've done, from referrals outwards. All of it kind of comes back to the same thing: grief and loss. And the loss could also include some of the parent situations, right? So not just death loss, but also loss of family members because of divorce. The pandemic seemed to has increased that for some of our families are falling apart. And so we've seen that as loss of family members, loss of connections with them. So that increases the anxiety, that increases the depression. So it's all kind of just looping back into itself as we see our kids struggling and trying to find ways to support them.
So with the demand for clinicians going up, I'm assuming it is very hard to hire more in-school staff. And when you're referring to outside providers, it's also a challenge as well because they have long wait lists. So what other support services are you putting into place for kids who may not need more intense one-on-one therapy, but other ways that you can start to gauge what the levels of need are?
Is that for Felipe or for
Emily, why don't you start?
Okay. So we also rolled out a tier 1 intervention. So for those not familiar with multi-tiered systems of support, tier 1 is sort of an overarching intervention that's available to the entire school, or support that sort of touches all students. Being really intentional in creating safe spaces for kids on campus as we returned back to in-person learning. We created calming spaces on all of our sites. And so a calming space is a really intentional area of the school that's set up usually in the Mental Health and Wellness Center on our site, that has low lighting and soft music and has a lot of different ways that kiddos can self-regulate. So kind of utilizing some of their own internal coping, or some maybe, coming in and drawing, coming in and painting, coming in and taking a mindful minute and doing like a quiet meditation, right, with their earbuds, those types of interventions. So we really wanted to empower kids to be able to take a pause, right? The transition back from being at home and isolated to these big school sites with 2,000, 3,000 kiddos on site can be overwhelming. And especially, like Felipe saying, with the higher levels of anxiety, kiddos' ability to self-regulate is impacted. So we created those spaces across our district, and that has been really a successful intervention. I pulled the data, and we had 13,877 unique visits to our calming spaces district-wide. So kids are utilizing those spaces. We also set it up as an expectation across the district with teachers that kids can ask for a pass to the calming space and take that 15-minute timeout to self-regulate. And that's been really effective. So we encouraged our entire school population to support this, right, practice. So that was one of the ways that we kind of just, another way to respond to those lower level, right? Maybe like a kiddo that doesn't need individual therapy, but is needing access to some supports. And those spaces are manned by either one of our full-time social workers or one of our interns. And sometimes out of those visits, then we're able to identify a kiddo that maybe does need a check-in, right? So that serves as sort of the first place maybe that they're accessing some of these mental health and wellness supports. We were really intentional too about doing tours at the beginning of the year. So classrooms were invited to walk through our calming spaces. We did a lot of lunchtime activities, tabling, having journaling, just modeled at lunchtime. So a lot of ways to push out into the greater school community and have kids get kind of folded into mental health and wellness, kind of making it just sort of a part of the culture of the school. So we've done a lot to do. We also had Furry Friends visit at a lot of our sites. So that's an agency that brings animals for kiddos. Oftentimes kids use their pets to self-regulate, and petting a dog or a cat can be very, very therapeutic. So we had lunchtime visits in many of our programs across the district by Furry Friends. So those are the type of sort of alternative interventions that meet a greater level of kiddo, and really kind of acknowledging that every kid is dealing with some level, right, of adjustment as we're coming back to in-person learning.
Emily, that's so fantastic. I wish that these centers have been put in place a long time ago. And I love how you're normalizing, these safe places that kids can go. It's really fantastic. Felipe, anything you want to add there?
No, I was actually taking notes on what Emily was saying too. So I think it's great. That you're able to do those things. And as we enter into this new school year, we're looking at expanding and bringing more onto our campuses as far as social workers. So it's great to hear what other folks are doing, so we can, borrow some of those ideas and see how it would work for our schools. We have 2 other social workers in the district, and for us, our one focuses primarily on foster youth, and the other focuses on an intervention program, but also does counseling with our other students. And the limitations that we have right now, just based on our personnel side of things, how many people we have to do the jobs. It's hard because when you care about kids and you want to do something for kids, you're willing to overextend yourself to help kids and find ways to support them. And I find that my team is willing to do that. But then we look into the burnout, right? We look into the stresses of compassion fatigue and things of that nature for our own staff. So the more that we're able to provide, I think is takes us into another level of support and able to decrease the wear and tear on staff itself. But so I love those ideas. I think that what you're doing in your district is amazing and wonderful. So good job.
That's why we're here today, so that everyone who's dialing in can hear about all of the fantastic things that different districts are doing to really help students with their mental health. Felipe, I'd love to ask you, you mentioned virtual therapy earlier, and sometimes people can be hesitant at first about this concept of virtual therapy, and I'd love to hear how it has been going and how it complements the in-person support that you do have.
Yeah, so as we entered into virtual therapy with Daybreak, there was some kind of feeling like the kids are not going to want to do this. They just got off the computers. They're not going to want to do it. There's the screen fatigue is there, and they're just tired of the screen stuff. So there was some hesitancy with our staffing when we talked about the program and implementing, and we said, this is just another support, another way that we can help kids, because we do have limited folks in the room, right? So limited boots on the ground, as they say. So we need to find another way to help, and that was Daybreak was our option that we brought in. So as we started rolling it out to the students. Some say, yes, that would work for me. Some others say, no, I need somebody live person sit with me. And in having that option really kind of balanced out some of that waiting list piece that we did have, was because we had an option for the kids who said, yeah, Daybreak would work because the virtual is going to work for me. Actually, I prefer virtual. I prefer not to be in the room with somebody, and prefer to be able to do it in my room as opposed to doing it at school. Or so that was a good option for a lot of our students. Whereas those who want to be in person, we were able to do that for them. I think that when we look at how the therapeutic process works, and we look at what the rapport building cycle looks like, and how much time you do spend in rapport building, to really create that therapeutic relationship where kids want to come back, especially our older students. Our younger ones are easier, right? You throw some Play-Doh, some Uno, or some kind of game with them. Our older kids are like, oh, come on. It takes a little more to get engaged with them, and they want to know somebody who's interactive with them, or has an interest in what they have an interest in, or can relate to them. Because our world right now is all about relatable, right? Like, it has to be relatable for me to engage with it. So when we look at the way that Daybreak does match somebody with our student, they're taking that into account too. Kind of some of those likes and dislikes, and things that are relatable, which does help with the rapport building. So the virtual piece ends up not being as scary for our students, because they have somebody on the other side of that who is relatable. And also, there's not that pressure of you have to turn your screen on, right? Some of our kids experience that during school. You have to have your screen on in order for us to know you're here. And the therapeutic process allows for that to say, hey, when you're ready, you can be on screen. When you're not, then that's okay. Don't be on screen. So it's allowing us to be there with the student in that way. So the therapist from Daybreak are being flexible enough to say, yeah, you could be on screen, or you don't have to be. And that's, you want to talk, with the black screen, that's cool. You want to talk with the ceiling showing, that's cool. So that's allowing that flexibility to build that rapport where they eventually do put themselves on screen and do, meet with them in person.
Emily, I know you and I have talked a lot about therapeutic alliances, and how the stronger the alliance, the better and stronger the outcomes are. Can you tell us about how your kids have been able to really build these strong relationships with their therapists?
Yeah, I've done some reading on sort of positive outcomes in therapy, and it's not surprising, but really the number in terms of correlation between positive outcomes and that rapport, right? That trust and that relationship. Positive outcomes are really highly correlated to that therapeutic alliance that's formed. This is really important. Felipe kind of touched on it with high school kids. They'll decide a mile away whether you're someone that they're going to talk to or not, right? Like, they are no nonsense, no BS, right? My teenage kiddos, and they will size you up and decide if you're someone cool or not real quick. So, so whether or not they're going to work with a therapist, that initial session is important, right? You got to kind of grab them. So, and my clinicians are really good at this, right? My clinical team, we have kids all the time that are like, I don't want to have a therapist. I don't want to talk to you. I don't want therapy. And then once they've come in and hung out with us, then I would say, can I check on you next week? We're not doing therapy, but like, can I check on you next week? And they would say yes, right? Because that connection was built. I was really hesitant, just like Felipe mentioned about the virtual piece. I was not a strong supporter when it was initially presented as an option, just because I felt the same. Kiddos were really, at max capacity for the virtual piece. And I have been pleasantly surprised at how many of our kids that we've referred to Daybreak have continued on in the therapeutic process, have made it to their second appointment, and have engaged. And that's all because of the the alliance that's built and that relationship that they're building with their clinician. I also love that because Daybreak is virtual, the ability to access a wider range of clinicians is there. And so I think that that has lent itself to really matching intentionally, right? When my clinical team is making a referral, they are maybe noting in the referral, kiddo would prefer an LGBTQ therapist. Kiddo would prefer, a male identified therapist. Kiddo would prefer a therapist whose first language is Spanish, right? So we really are able to ask for exactly what our students are needing and then hopefully have that need met. So I've been impressed with the fact that our kids come back and report to us. So if it was not a good fit, they would be letting us know really quickly, probably, right? I can't tell you how many kids have come to me and said, yeah, I have an outside therapist, but I'd rather talk to you, Miss Zavala, right? We're not hearing that with our Daybreak kiddos. We're actually hearing, oh, it's going well, right? I like my therapist and I'm going to see her next week. So that's really important to us because when we make a referral, if it's not a match and it doesn't work out, guess what? That kid ends up back on our wait list and back in line to see us again. So
Emily, I want to ask you a quick question about referrals because I saw this come in on the chat and someone asked who is making the referrals and how does that happen? Can you talk to that?
Yeah, so at my district, again, and I know we're special that we have 28 social workers. So we decided, my director and I, when we rolled out Daybreak, we decided that that would be held by the social workers on our team. So every site has 2 social workers per site. Those referrals for service come in just into our regular referral system, and then they're initially assessed by one of my social workers on a site and then referred to Daybreak if it's the right fit, and not every kiddo is.
That's great. Felipe, anything you want to add on referrals?
Yeah, on the referrals, so we did it a little bit differently because we started small with ours. When we started our contract, we started with about 50 students. So that was kind of a test run to see if this would work out and how our students would respond to it and our staff. So we didn't push out to teachers. Teachers aren't really, they know now as a byproduct of people talking about it, but not so much, it wasn't advertised to them. So we went straight to our counselors and straight to our admin, and then brought in our school psychologists, but not really heavily pushed it to them. So our referrals come from our school counselors in our middle schools and high schools. And then also myself or my mental health team, who primarily work with our special ed department. So that's where our referrals come from. The cool thing about the referral system, and I agree, that Emily was saying about, like the matching stuff, it's like I had a kid that wanted anime, right? So I want a therapist who understands anime, right? And thinking that would not happen. We're not going to find a therapist for you that gets into anime. Well, there actually was a therapist that was into anime, and so that kid's really happy. So yeah, it's like those type of things were really positive because a kid thought that they put up a barrier that we weren't going to be able to meet that barrier, but through the matching process they were able to do that. But the referrals that we've been able to do with our students have come from our counselors primarily and come from our admin, and so that's been a really positive thing because our admin have gotten involved with the mental health process as well, not just allowing the counselors to manage it, but also doing the referrals themselves and seeing how easy it is, which actually supported our counselors in doing more because an admin does it and says, hey, this is really easy. This is a good process. You should give it a try, which then promotes it to them to say, okay, let's give it a try. And then they try it and they're like, yeah, this was pretty easy. So that really does help. The referral process is a simple, few steps that get managed really quickly. And parents have been able to do self-referral in a sense too. I've been able to give the link to parents and they decide when they're ready and they do it themselves. So we've done that with some parents as well. And that's been very beneficial, when the parents take kind of the helm of it, because we have parents who want to be in charge of what their kids do, which is their right. As a parent, I want to protect my kid too, and make sure I know what's going on. So our referral process, we've been very flexible in those ways. And this next year, as we go into our second year with Daybreak, we are going to be pushing more out to the teachers and letting teachers know so they can, do the referral or bring the referral information up to the counselor so they can check in with them.
I love
but yeah,
the idea of getting the whole community as being sort of
yeah,
allies in this
absolutely.
ecosystem of care. Felipe, I'd love to talk to you a little bit about data, because I know a lot of the districts that we talk to, yours included, are beginning to really explore data to better understand how they're serving their students' mental health needs across the community. And I know that you launched a universal mental health screener to look at key indicators around academic success and gender identity. And I saw a lot of questions coming through in the chat around percentages of boys versus girls and LGBTQ. So I'd love to hear from you what that universal screener revealed and how it changed how you were thinking about supporting their needs in the future.
Yeah, the universal screener, I have to be honest with everybody that it didn't come with a lot of positive when we first brought it up. There was a lot of resistance because it's like, well, what are we going to do when we get this information? How are we going to help them? What if there's too many kids and we don't know what to do with them? So there was a lot of resistance, which is natural, right? Like anything new, and if we pull up too much, if we pull that Band-Aid off, how much blood's going to come out of it, right? That's kind of that feeling. It was a little bit scary. But once we got into it, once we got the information, what we are able to see now is that in our secondary schools, because this was our middle and our high schools that we did this at. So what we're able to see is the specific needs for the specific sites. And having that information is really useful because then we're not looking at every school gets the same service, every school has the same need, because it's not accurate. But now we're going to be able to accurately support the school site and saying this school has a higher need of grief and loss and anxiety, or depression and anxiety, not so much grief and loss. So we know what services need to go to that school. We can provide better groups as we go forward. We could provide better supports to the students and just kind of address things as a global system of saying, for this high school, we really want to put these supports in place, or for this middle school, we want to do the same. So we're able to look at those specific needs. So we're able to look at, which school has the higher level of anxiety, or students who have anger management needs, which actually ended up being a lot lower than I thought they might be. I thought there might be a lot more anger, but there's less, so it's good. But we do have, the anxiety, the depression, and the grief and loss. Those are our top ones at many of our schools. So we're able to now look at those things and say, what can we do to put in place to support the kids in those areas? Using that data is really helpful. But it was one of the things where it kind of made people a little bit nervous. But I think now that we have the data and we're able to now share it out with the schools and address those specific needs, it's going to be really beneficial going forward. I think I saw a question about how many students do we have in therapy. But like I said, we had 50 students to start with, but we at this point we have over 55 referrals in, and I believe 37 students in treatment right now. So we have quite a few students using our service that we have put into place.
Emily, I'd love to talk about equity and access to care, because we know that the mental health system is complex. It can be extremely hard to navigate. And frankly, it isn't affordable for a lot of families. And so how has your district tried to make mental health care more accessible, including, socioeconomic status, including, families that English is not their first language? How have you been able to address that?
So equity is definitely something that we think a lot about in our district and really want to make, all of our systems accessible, right, to all of our families. We do have a lot of, monolingual Spanish and Vietnamese speaking families. And so that has been, first of all, in our partnerships, I would say a lot of our community-based organizations use Medi-Cal billing to fund their programs. And so that means that they're able to serve on our sites through sending clinicians out to our sites, but they can only take kiddos with Medi-Cal. So honestly, when we have kids that are sitting before us, we have more options right off the bat when they do have Medi-Cal as their insurance than we do, let's say, for one of our Kaiser kiddos or one of our, private insurance kiddos that have wait lists that are 2 months long to get in for initial. We also have noticed that even in our community-based organizations that serve our Medi-Cal families, they are understaffed. They're not able to, fill the open positions for therapists that are they're left with. And so there's a shortage of clinicians kind of as a overarching problem. And so that has proven difficult, right? And we cannot see every kid. So that's the thing. The need is so high that it is impossible, even with 2 site social workers that are there full time. We cannot serve every kid that needs it. And what I love about Daybreak is I don't have to ask an insurance question because so it doesn't matter at all which insurance that our kiddos have. That's no way an indicator of how I can refer and how quickly I can access services. And what I've found this year is it doesn't matter what insurance a kiddo has, there's still going to be a wait time, period, right? Whether it's Kaiser, Blue Cross, Blue Shield, Medi-Cal, right? Because they're understaffed. So the fact that our district is paying for these hours means that I can refer a kiddo and they can have their intake the next week.
Felipe, anything else?
No, I absolutely agree. Those are all good points because that's what we were looking at too, is students who still have to wait, but they have a need and there's an obvious need, and they have insurance, but they can't get services. When it takes 2 months to get just even an intake appointment to see somebody, that's hard. That's hard when somebody's dealing with a severe depression or with a grief and loss issue. And so when we're able to say, we have something for you, you could feel, if it's on the phone, I was on the phone with a parent and I was like, we have something for you. And you could just hear that sigh of relief, like, you can help my kid. Okay. And, then you're able to help their child feel better, get what they need, then you become like a hero, and it's like you've saved the day in the sense of you found a way to help them with what they can't get help with when they're on the phone constantly trying to find somebody to help their child. So it's a good feeling. It's a good feeling knowing that we have something that we can offer to our students and to our families to help them get through that harsh moment of whatever they're going through. Because obviously we don't want to lose any of our kids. We want our kids to thrive. We want our kids to be healthy and safe, and obviously make good choices with their lives. So if we can offer something that will help them do just that, then I think that's our best option. Obviously, if we can help them, assist them with getting outside support, we're going to do that as well. We're going to do all the things that we can do, but having one more option that we could say, here's something we can do for you. Even if it's, let's do Daybreak for now while you're waiting for your insurance, because we know this is going to be a long-term setting for your child. Your child's going to have a long road ahead of them. The 12 weeks that we're doing with Daybreak is not going to be enough for your child. We get it. But let's do this while you continue to make those phone calls, while you continue to work with your insurance, because by the time we get there, your kid will have some skills. Your kid will have some opportunity to share out and to feel something and to get a little bit better, and maybe a lot better, depending on how they work the therapeutic process. Maybe they'll get a lot better. Maybe they'll be more successful in that. So we give them that option and we give them an opportunity.
So I'm going to go over to the questions that have come in the chat. And, we've talked about how youth mental health has really been suffering, at increasing rates over the past few years. But I can't even imagine the strain and stress that's on the counselors and the social workers that are working in your district. So what are you doing? I think you touched on this a little bit, Felipe, but what are you doing to support them?
I saw that question come in, and I love that because first of all, they created my job. So I was a site social worker for years within our district, and our district prioritized having somebody here that's sort of overseeing just that piece, just the mental health and wellness piece, taking some of the stress off of my site-based social workers who split up the work of doing my job while they did a full-time social work job at a site. So they created my role. We have monthly clinical team meetings, which are very therapeutic. The last one, a lot of people were crying and just sort of like supporting each other through what's been a really rough year for all of us. So that intentional time together, there's food and, there's a check-in question that usually takes 45 minutes because we're a big team. And so we come together as a team intentionally. I offer clinical supervision groups to my ASW team members who are working towards licensing. And so that's another time that is held for 2 hours a week, once a week. And so that's time that we're supporting each other. So I really think that what clinicians need is the space to vent, to say this is hard, and to be acknowledged. I think another thing that helps with the burnout is we've really become an integral part of our school sites. And so I find that there's a lot of positive feedback that comes from that, right? From teachers and from administrators and from counselors. When I was a site social worker, a lot of staff members would say, I don't know what we did without you, because I can't imagine not having you here on our site. So that also feeds, right, and helps counterbalance the kind of high stress levels. So those are some of the things we do.
Yeah, and on our end, we have like I said, we have a smaller team, so we do try to support each other. Between myself and the two other social workers, we meet weekly to kind of go over things that are going on for us and kind of process it, as well as going over our referrals and things of that nature. We talk about the different things that are going on to our sites. We try to make ourselves available to our teachers and to our counselors and to our staff. So if they ever do want to talk, we try to make ourselves available to help with those types of things. For my specific teams, the folks that are underneath me, I got them all a book on compassion fatigue this year. That was their Christmas present. It was really to just help them recognize that we are in a different kind of a year, and that we need to, take time for ourselves. And I try to remind my teams to remember to take time for themselves and to be mindful of themselves and their stress levels, and then also to be intentional about taking time with their families and loved ones, so that way they can spend time and let go of some of the stuff that they're taking on, because it's a lot. It's a heavy year. Most school years are heavy, but this is a heavier year where we came back into a different kind of a school year with masks, and then no masks, and then maybe masks, and then where we're at now. And all the different feelings, the political unrest that was going on as everybody was watching it because they were at home, and you had no choice but to watch what was happening in the world around you. And that created a lot of stress for our kids. The stuff that's going on in Ukraine right now is creating a lot of stress for our kids. There's a lot of worries about what's going on in the world around them. And that translates into what happens at our schools. So being able to support our students and then our staff as well, and being open and available to them when things happen, is something that we try our best to do. And then of course we have our EAP systems and things of that nature that are in place to that they can refer themselves to and get support that way.
What happens when, oh, Emily, did you want to say something?
I was just going to say, let's say our December get together is not a working meeting, it's a party meeting. And then our end of the year, we celebrate our interns. And when I have administrators push at me, I push right back and say, yeah, we're going to take the time to celebrate and to have a party and to just be together. So I think also like that piece is really big, is to just building into the workday some space for those people that are on the front lines and holding a lot of this to decompress, right? And that may take administration saying, yes, my counseling or social work team is going to have an offsite lunch, once a semester or whatever it is. So I advocate strongly for those spaces to be created for my team.
They absolutely need it. So there's been a long-standing stigma with getting mental health support. Have you seen that from families or students, and how have you dealt with that?
I think I'll jump in. I think for us, I've had that. I've had a couple phone calls with parents and talking about the stigma. Well, talk about how they don't believe that their child needs counseling, or they don't think that they need that level of support. Why would the school recommend that? And as we discuss things, by the time we get to the end of the conversation, they're ready for support for their child. And I think it always comes back to the education piece. When you learn more about what it really is, what therapy really is, and I was talking with the parent once, and we had a long conversation, and I said, "Do you realize that you and I just had a therapy session?" Because it was just this whole unloading, and oh, that's what therapy is. And that kind of helped her get through that stigma piece of what was going on, because it wasn't really as bad as they thought it was going to be, right? Unfortunately, sometimes the media and the movies and videos, they don't really depict therapy as something that is a welcome process. A lot of times they show the therapist, dodging out during the session and coming back in, pretending that they were listening the whole time. And that's not really what it's about. It's like most therapists are in the industry because they care. And, helping people understand that that's what it's really about, is somebody who is not connected to you, not part of your life, doesn't have any biases, is going to listen to you with just what you have to say, and then help you process and learn how to move forward from there. That's really what it's about. And that's how we want to help. Once they get that education and learn more about what therapy really is, it seems to me that the stigma starts to fade, and they become more aware and more available to it. And getting past some of the cultural biases is a challenge as well. And helping, the different cultures who see it as a weakness to share your feelings or your thoughts. It does shift things, and as a male, and it's one of the things too, right? Males a lot of times culturally don't want to show weakness. So when they see me being available to do those things, then it helps a little bit.
Yeah, I think I would agree, right? Like that piece of joining with a family and partnering with them and offering some psychoeducation does tend to take down maybe that initial resistance. So that's a big part of what we do on sites as part of our work. I also think that offering for us this year, we offered a more varied sort of access to therapeutic interventions. And by that, I mean, we brought on East Bay Art Therapy, and they come in and do art therapy groups, right? But it's not traditional therapy. It's not one-on-one. So maybe it's a little more accessible, maybe to a family that has some resistance. And then it's like, hey, I'm going to be in this art group, right? We also offered the Art of Yoga, who's come in and run yoga movement interventions for our kids. And so that access is, that opens up access. So I think for us, it's been creating spaces that maybe are entered into in a different way, and so then become more accessible. One of our organizations who I have a lot of respect for, the Compadres Network, runs a group called Joven Noble, right? So the young noble, and we have male groups and female-centered groups in that area. And those groups, I think, also create a really safe space for some of our kiddos that would be the traditional resistant to a therapeutic intervention, right? Like maybe our gang involved youth, kiddos that are getting in trouble for fights and that kind of a thing, all of a sudden are part of something that is really group therapy, right? But they're into it because it feels different. So I think that that's been a part of it as well.
Yeah, it's so important to meet people where they're at. And, I love the concept of destigmatizing mental health, starting with families as well. And I know we've worked with a lot of districts providing educational courses and classes to try and really teach them how to be a part of the solution and help their kids as well. How do you, Emily, I'll start with you. How do you delineate between a student seeing an in-person social worker or therapist versus telehealth?
So I would say, obviously it helps if our kiddo is sitting before us in our initial assessment and we're able to assess whether or not that's something they're open to, right? Would that be an appropriate intervention? Maybe it's a placeholder, just like I heard, because for Kaiser, it's now their wait list can be up to 2 months long, right? So in between, they can have 10 sessions potentially. I originally thought that it would serve a lot of our ISP kiddos, our independent study program kiddos who are not on campus other than once a week for a few hours. But that hasn't been the case, because some of our kids will elect to go with Daybreak and then actually have their sessions during the school day in the mental health and wellness center in a private room. And so what it's looked like has really been, because we're assessing each kiddo individually and asking them whether or not that would be something that's appropriate. Also, I think that we're looking at what are the presenting problems, right? And would this be an appropriate fit given that it's a 12-week model? So we kind of consider all those pieces. But ultimately it comes down to, is that something that the kiddo is open to?
Great. Let's talk about outcomes and how you are measuring, the success of these mental health programs that you're putting into place. Felipe, do you want to talk to that first?
Yeah, it's a little bit challenging when we think about how the educational model works, because the educational model looks at attendance, grades, and behavior. Not everybody has those issues, right? So there could be a straight A student who has no behaviors and perfect attendance, but be completely imploding with depression or anxiety. And you would never measure it in a typical educational way. So we've been struggling with that, honestly, about how to measure those students that we're referring to Daybreak, because now they're asking for help. And we're giving them supports, but how do we measure in the same way that we would measure a typical educational setting, right? I think anecdotally is how it ends up coming out, is the teachers start reporting this student, although has always been an A student, has always done well, always shows up, their mood is better. They're coming to school and they seem to be happy. The parent report is that their child is engaging more at home. They're being a part of things as opposed to withdrawing, because when they get home, they just seclude. And before, parents thought it was they're secluding to study because they want to maintain that 4.0 and stuff, but they were secluding to cut, or they were secluding to do something else, just because they were so depressed. Maybe they were just going home and sleeping. So anecdotally, we're getting more information that way. So we're looking at different ways to really measure more on the qualitative side, the quantitative side of how do we measure this and success that the students are having, because we can't always rely on the academic way that we typically measure student success. So I'm open to ideas. If anybody has some, feel free to send me an email on that. But when we first started looking at it, that's what I was tasked with, was measure the students with the academics, with the attendance, and with the behavior. And when I come back to my leadership and say, not always going to be the case. It's not always going to be easy to measure that way, because a lot of our kids are going to be good students showing up to school because maybe school's their safe place, so they don't want to be at home. And so their attendance is going to be great. Their behaviors are going to be fine because they're just internalizers and they don't show it outward. So now we're looking at things differently. How can we measure it differently?
Yeah, I love that you made that point, because I myself as a clinician, right, like just those markers, because we're in education in our practice, don't always capture, right, the struggles that kiddos are having. So I love that point that you made. We do a strengths and difficulties questionnaire when kiddos start services with us, and then when they conclude services with us. So then we look at that data to kind of give us feedback on, was the group successful, right, in increasing some of their functioning? And, are they having less difficulty, right, in certain areas of their life? So we use that as a marker. We also have our kiddos do a quick little checkout of our checkout questionnaire through Operu that measures the level at which kiddos self-identify them coming in at, and it's a scale, right? Kind of 1 to 7 being, highly dysregulated, angry, upset, to, peaceful and calm. And so we're seeing those numbers, have a change of at least 2, like kind of as an average during checkout, and towards the positive, right? So maybe they come in highly dysregulated and are super angry, and then on average, improve by two rankings on a scale of 1 to 7. So that's another way that we're measuring outcomes. That's for our calming space, right? Like, how useful is that? And then, yeah, no news is good news in my field, right? When I was an on-site clinician, if I didn't see my kids, it meant that they were usually functioning pretty well. I saw them when they were not doing so well. I loved the visits where they came in and said, Miss Zavala, like, I'm rocking at life. But I would say that the lack of need for supports is what indicates to us that kiddos are doing well. We're definitely not there yet. I know with Daybreak in particular, they give progress reports at session, I believe 4-8. Is that right? 4 and 8 or 5 and 10?
Yeah, we'll confirm that in the chat. I don't want to give any misinformation.
Yeah, so that feedback to my team about how kiddos are doing and are they meeting their goals for therapy is helpful.
We are just about at time, so I want to take a moment to thank you both so much for your thoughts and insights. I know that I learned a lot today, and I hope that the other school districts have been able to take some key things away from this as well that they can implement in their schools as well. But again, thank you all, everyone on this call, for everything you do to support the mental health needs of our kids every day. Again, thank you all for joining the webinar. Before you go, if you want to learn more about Daybreak Health and how we partner with schools to provide multi-tiered mental health support for students, please reach out. You can contact us at connect@daybreakhealth.com. We'd be more than happy to talk with you. And again, thank you all and have a fabulous day.